Hi, good afternoon, everybody. We're just going to give our attendees a couple more minutes to sign in. Welcome, everyone. I'm Julie Flannery with Caron Treatment Centers. Thank you for joining us for today's webinar on the topic Value-Based Agreements, Revolutionizing Addiction Treatment and Improving Outcomes. As a reminder, we will be conducting this session in webinar format, meaning all participant microphones will be muted. We will not be able to see or hear you. During the presentation, please utilize the Q&A or chat features to ask any questions. Depending on the volume of questions, if we can't get to your question before the end of the hour, we will have someone from our team follow up with you directly. Today's presentation is eligible for 1 continuing education credit. We would like to thank our educational partner, CE Learning Systems, for assisting in providing these credits through co-sponsorship with the American Psychological Association. Please note that in order to receive your credits, you will need to complete the post-webinar evaluation. A link will be emailed to you after the presentation from cego.com. After finishing the evaluation, you will have immediate access to your certificate of completion. Today, I am proud to introduce our presenters, Dr. Joseph Garbely and Brad Sorte. Dr. Joseph Garbely has over 20 years of experience in the field of addiction medicine, including treating substance use disorder in healthcare professionals, executives, and pilots. He currently serves as the Executive Vice President of Medical Services and Chief Medical Officer at Caron Treatment Centers. During his tenure at Caron, Dr. Garbely spearheaded a high-level initiative to educate and train physicians in addiction medicine through the establishment of the resident training program at Caron, Pennsylvania. As the Addiction Medicine Fellowship Director, Dr. Garbely is a member of the American College of Academic Addiction Medicine. He is also a clinical associate professor at Penn State College of Medicine, an adjunct associate professor at Stony Brook College of Medicine, an adjunct associate professor at Drexel University College of Medicine, and a member of the medical staff at Reading Hospital. Dr. Garbely is a chairman of the Physicians in Training Committee of the American Society of Addiction Medicine, an ex officio member of the ASAM board, and a distinguished fellow of ASAM. Next, we welcome Brad Sorte, President and Chief Clinical Officer-elect for Caron Treatment Centers. In his role, Brad guides and drives projects across the organization in alignment with Caron's strategic plan. Brad also oversees Caron's 7 regional recovery centers along the East Coast. In addition, he has oversight for Florida's Kiel Center and site operations and all non-residential services along the regional continuum. His previous experience in business and clinical leadership in Caron's Florida continuum continue to inform his work. He remains committed to his goal of providing a culture in which the business of healthcare never interferes with the fundamental needs of each individual patient. Brad speaks at conferences in the United States and abroad on topics ranging from family recovery and young adult addiction to the changing landscapes of behavioral healthcare. I will now hand the presentation over to Brad to get us started. Thanks for joining us today.
Thanks, Julie, and thanks to all of our guests who are joining us here this morning. And I look forward to taking you through the next hour or so here, talking about some of the things that we've learned through our pilot program of value-based care in the treatment of substance use disorders. So to set the stage a little bit, just looking at some of the learning objectives here, I really look at this as kind of two broad categories. First and foremost, we want to define and describe how value-based agreements work in the context of behavioral health care. But then probably most impactful for those who are going to be joining is to have a conversation around the tangible takeaways that can inform best practices, both in terms of facility changes to be able to implement these practices, as well as for those of you who are working in partner type practices and other professions, to better understand how this can be of benefit to our mutual clients. So to do that, I think that it's helpful to go back to the beginning. So if we're really looking at how best we can evaluate the efficacy of value-based agreements in substance use treatment, we think we need to take a little bit of time to look at what has been going on in today's treatment paradigm. So we know from the research and from the iterative process of experience over many years that substance use disorders are chronic and lifelong illnesses. However, much of our treatment model has historically been provided in brief episodes of care where there's a lot of resources and a lot of energy dedicated to the treatment of the acute phase of the illness, and the embracing of a fully chronic illness methodology to treat individuals and help to ensure their care over the long term has only really begun to gain some traction. And some of the things that are related to this that stand as a barrier for effective care are the slow pace that medication-assisted treatment got utilized, which has accelerated in the past 5 years, but really had a slow start for our field, and the continued siloing of substance use disorder treatment from the rest of medicine. Again, another integration that is well underway, but at the same time, long overdue. In addition to that, as we begin to take a look at the problem as we are facing it, is we really have two major issues in substance use disorders in the United States. The first one we have is we have over 20 million people in the country at any given time who meet the criteria for any substance use disorder. And so we've got some great statistics here, just kind of giving you the broad strokes. Nearly 15 million people in 2018 with an alcohol use disorder, 8 million illicit drug users, and just around 2 million who have an opiate use disorder. So the magnitude of this problem in our society is something that is very, very significant. And in these numbers, it doesn't even really count all of the people who don't yet meet the criteria for a substance use disorder, but would be in the category that we would refer to as being at risk. The other problem that we have is that of those 20 million or so people who have a substance use disorder and are in need of specialty treatment, really only a small percentage of them in a given year are presenting to a program. And the vast majority, nearly 95% of them, don't feel that they need treatment or do not want to get treatment. So we have a large problem that's affecting in an indirect way just about everybody in our society. And we have that confounded by an equally large problem that of that population of folks who need help, the vast majority of them are not going to get help in a given year. And so those two things are working together to create problems. As we turn our attention to the reimbursement model that has historically existed in the treatment of substance use disorders, we have a couple of other variables that come into play that create challenges. The growth and evolution of managed care really drove an incentive towards programs focusing on the acute phase and the management of the illness of substance use disorders. There was a heavy focus on managing costs. There was a heavy focus on justifying why ongoing care is needed, and a heavy focus on moving people to the lowest level of care available as quickly as possible. As a result of that, we saw in lots of settings a cyclical nature to the experience where people were able to receive care at these acute levels. However, there ended up being a revolving door because the end game largely wasn't getting managed in a way that could help people have success over the long term. The focus on expense management created a vicious cycle of austerity and reduction in resources and care for individuals to help organizations remain sustainable. And then for a period of time there, we also saw the growth of other streams of revenue such as lab revenue that were uncouth in their manifestation and exploitative in many settings where they were occurring. So as a result of that, we began to see a bifurcation in the private insurance population, where programs began to go private pay, allowing the care to truly be directed by the clinical team who was treating the individual, but done in a setting where the cost of accessing that care was unattainable for many individuals who were reliant on using their health plan to underwrite their treatment experience. So one of the things that was looked at in the context of value-based agreements was the idea that it's not just about the costs associated with somebody coming into treatment or coming into treatment multiple times, but that for the payer, moving somebody into a subscriber into recovery from a substance use disorder has a positive effect on the number of health services, preventable health services that individual will use over the period of time that they are in recovery. And so one of the statistics that came out from that was from the presentation that Dr. Garbely and Dr. Rich Snyder from Independence Blue Cross did this year at the RX Summit, which showed that for an opioid use disorder who received treatment, the annual decrease in healthcare costs to Independence Blue Cross was $10,000 per year. So we're seeing that by people getting appropriate treatment for their substance use disorder and getting into recovery, there are fewer health expenses that they are incurring on a go-forward basis. And we're also seeing that there's an improved quality of life for patients. The risk of us not being successful in continuing to advance these initiatives is stark. So that's a big number, 183,000 alcohol or overdose related deaths in just a year. To put that in context, we are looking at a loss of life, in a year that is about half of the American loss of life in World War II. So to talk more about what value-based care is, I'm going to turn it over to my esteemed colleague, Dr. Joseph Garbely. Dr. Garbely, the floor is yours.
Thank you, Brad. Excellent job as always. And I'm here to talk to you about our value-based contract. So let me.
Dr. Garbely, I think you're on mute.
Oh, you did unmute. I did unmute. So again, thank you, Brad. You did an excellent job. And I'm here to talk about our value-based agreements. And again, I want to say, if the glare from my head distracts anyone, I apologize. But let's look at what a value-based agreement's all about. It incentivizes cost effectiveness. And it really puts a premium on quality of care rather than quantity or volume of fee-for-service care. And value-based agreements are linked to define quality metrics or demonstrated value, providing evidence-based practices. It also emphasizes bundled payment models of specific treatments or conditions, or pay for performance models that reward measurable aspects of care. So I'm an internist, psychiatrist, and addiction medicine specialist. I spent the first quarter of my career as an internal medicine physician. So I was around when standards of care were set because of good outcomes. So when you look at the standards of care now for myocardial infarction, for cerebral vascular accidents, for hip replacements and knee replacements and cancer care, they all came out of outcomes. And that's what we're talking about today. And an example here, it can establish standards of care where none existed. And the ICHOM initiative helps set value-based outcomes for breast cancer, which were so important, so that every provider knew exactly what was the best treatment given the stage of breast cancer. And that has helped survival rates astronomically. Next slide. So let's look and see what happens around costs. So the thought is maybe this would increase costs, but actuality is that it decreases costs. And on the x-axis, you see healthcare costs, and on the y-axis, you see time. And over time, with these value-based agreements, some of which I mentioned in physical medicine, you see a decrease in costs, healthcare costs, in a value-based program. And that's because a value-based program aligns financial incentives. Its robust clinical claims are a data exchange between the payer and the deliverer of care. There's an emphasis on clinical care transformation and a focus on what matters to patients and members: access to well-coordinated, high-quality, affordable care with a good experience. So all this conspires actually to good outcomes, and good outcomes actually lead to decreased healthcare costs, which is intuitive. Next slide, please. So no outcomes plus no standards is a broken trust. And we've been dealing with this in our industry for quite a while. So reference and primary care providers, what this means is that their patients don't get better. And there's a great struggle in how to identify what is a true substance use disorder and what is quality of care. And I'd add, and what is the level of care if there is a substance use disorder that the patient should enter. Payers, on the other hand, what should substance use disorder treatment consist of? They are not the experts in substance use disorder treatment. We are, those that provide substance use disorder treatment. And then who should receive treatment, and again, at what levels? And then who is providing the quality of care? What is the experience? What is the education level? What is the investment in quality providers? And in communities, Brad spoke of this already, we have just too many overdose deaths, and we have too many deaths associated with alcohol and organ disease. And for families, where do I go for help? They are exasperated, and they feel like the system is broken, and they become broke by going to treatment facilities that do not deliver high quality of care. So they spend a lot of money with zero results. Next slide, please. So some barriers. Let's talk about that before we get into some of the ways that we came up with our value-based model. So some barriers for substance use disorder treatment when it comes to value-based contracting. So substance use disorder grew up, if you will, outside of mainstream medicine. I know that all too well, as I started as an internist who did a lot of critical care work. So I understand that substance use disorder was outside of the mainstream until very recently, when we became part of the American Board of Medical Specialties. So now we're a fully codified specialty in medicine. There was no oversight. And so you can open a treatment facility without any accreditation and without any license in some states. And there's been a slow adoption of the chronic disease model of addiction. And we still want to say that this is a moral failing or a lack of willpower when it is most certainly not. Dr. Volkov and before her, Dr. Leshner have done amazing research at NIDA, the National Institute on Drug Abuse, that really prove beyond a shadow of a doubt that addiction is a chronic brain disease, which means that it's treated and not cured, which means that it's relapsing and remitting, and that treatment should follow a chronic disease model, which is to say that treatment needs to go on for life. There were inconsistent reimbursements as a result of growing up outside of mainstream medicine. Lack of oversight was the reason for that. And we really focused on acute and episodic treatment focus. And if someone relapsed, we would blame it on the patient. And in no way, shape, or form would that happen in cancer or a myocardial infarction or cerebral vascular accident, but it did for so long and still does actually for substance use disorder. And there's an inconsistent adoption of evidence-based practices. So there are many practices that really are not supported in peer-reviewed journals, haven't been studied well, but they are utilized nonetheless as adjunct parts of treatment. And I mentioned licensure not necessary to become a provider in certain states. I'll just say for us here at Caron, we are accredited by CARF. We're also accredited by the newly minted CARF/ASAM accreditation, which is a higher level accreditation. And of course, we have a license through DDAP, which is the Department of Drug and Alcohol Programming in Pennsylvania. So we here at Caron feel very, very confident in what we do and want to seek out all accreditation and all licensure to do the job well. And then there's that fail first model, which is to say that you must fail at a lower level in order to get to the appropriate level. That's not the case anymore, thanks to the ASAM placement criteria. We now have a fully codified set of requirements that tell us where the patient should start out in treatment. And then there's a stain of predatory marketing, which we'll talk about a little bit more as we go on. Next slide, please. So let's look at barriers to a value-based model in substance use disorder. When we set out on trying to sit at the table with Independence Blue Cross, we knew that there were going to be many barriers. And indeed, the conversations talked a lot about those barriers initially. And one of the barriers is, what outcomes do you use? For time immemorial, the outcomes in substance use disorder are a phone call to the patient after they have matriculated through our treatment program. And then you ask that patient, are you sober? Well, you know, that's really a question that can be erroneously answered. And the patient can say they are in recovery when they are not. And then how do you, another barrier is, how do you define a quality treatment program? What elements of the program help with improved outcomes? Again, outcomes are so important, and we need to figure out what a quality treatment program looks like to get the best outcomes. This is, again, borrowed from physical medicine. A lack of standard of care, defined treatment protocols existed in substance use disorder and still exists in substance use disorder. But again, as I said before, standards of care have been set in cancer, myocardial infarctions, cerebral vascular accidents, hip and knee replacements as a result of outcomes. And those standards of care really help physicians understand what they need to do to treat someone effectively. And that's what we have here at Caron, and that's what we need more of in our industry of treating substance use disorder. So mainstream medicine doesn't understand substance use disorder. There's a lack of training about substance use disorder in medical school. So as mentioned before by Julie Flannery in her wonderful introduction, I am the chair of the Physician in Training Committee for the American Society of Addiction Medicine. That's a national position. I've done it for 2.5 years and just was reelected to 2 more years because of the success we're having in setting core competencies in medical schools and allowing the medical schools then to come up with their own curricula to meet those core competencies. And this has been adopted across the board in medical schools across the nation. We still have work to do, but it is being adopted at breakneck speed, thank God. And the other thing is that we are working on same core competencies in residencies. We feel strongly that all residencies have to have a basic understanding, if not a deeper understanding, of what substance use disorder is all about and what are the standards of care. And we are now working with the ACGME to set those standards. And I'm very proud of the committee that I serve on and the fact that I'm chair of that committee and the help of SAMHSA to get the proper standards. So let's talk about standards of care and finding common ground. Next slide, please. So traditional substance use disorder treatment, there was a lack of individualized care. So it's a one size fits all. It doesn't matter co-occurring disorders or what else you bring to the table, family issues and things of that sort. You were getting the same care as someone that didn't have those same issues. And that still exists today, not here at Caron, but it does exist today. Treatment centers drive treatment plans, not medical needs of patients. Here at Caron, we do a series of high-level evaluations, and then we come up with a treatment plan, and the patient is authored to that with us, and they sign off on that. And it evolves over time as we find out more about the patient. And then where patients go equals where treatment is given. So it's important that the personalization of treatment happens at a treatment center, and that's where patients need to go. There's been a resistance to medication-assisted treatment, and that resistance is slowly but surely dropping. But it's so important with these life-saving medications to reduce relapse risk and overdose deaths. You saw the numbers that Brad presented. They are unacceptable in my book. And treatment focused on morality should be out the window. This is not a moral failing or a lack of willpower. This is a chronic brain disease and it has to be treated as such. And there are no accepted or inconsistent outcomes. There's no accepted and also inconsistent outcomes, as I mentioned before. And there's a lack of complete abstinence, which is deemed a treatment failure. Again, this is a chronic brain disease. It's relapsing and remitting like other chronic diseases. So we have to take that into account. Next slide, please. So this is Dr. Nora Volkov, who I had the pleasure of speaking to last week. She and her team are going to be speaking at our 6th annual research symposium. She is a dear friend of Caron and has really been an excellent consultant when it comes to quality of care and also the research that we're doing here at Caron. And this is an article that appeared in the Journal of Psychiatry, and it talks about personalizing treatment in substance use disorders. We've had long conversations together, Dr. Volkov and myself, about how important it is to personalize substance use disorder treatment, just as we personalize physical medicine treatment. Next slide, please. So this is a busy slide, so I'm not going to go through all of this, but it's important to understand that the intake and processing assessments, plural, that we do start with nursing as soon as the patient comes into our facility. Within 24 hours, we have 10 addiction certified, board certified physicians who will then do a history and physical within that 24-hour time frame. And then right after that, we have a team of 10 doctor-level psychologists that will do a psychological evaluation looking for co-occurring mental health issues. And then we have masters trained or masters prepared counselors that do a psychosocial evaluation. And those evaluations conspire for day 5, which we call an intensive case consult, which informs our treatment plan that the patient is part author to and signs off on. And it also begins the process of continuing care, which you see at the bottom there. So that treatment plan, continuing care are concurrent, so important. We use pharmacotherapy for co-occurring mental health disorders. We use medication-assisted treatment, not just for opioid use disorder, but also to decrease cravings and relapse in alcohol use disorder. So substance use monitoring after they leave, self-help peer groups are so important and the bedrock of caring since 1957. Clinical and care management is so important throughout the stay here. And behavioral therapy and counseling is so important for the co-occurring disorders. And let's remember that the outside here is how addiction affects individuals and families and their vocation in so many different ways. Next slide, please. So this is a slide from Dr. John Kelly, who is at Harvard, and he is part of our Professional Advisory Council. And he came up with 11 indicators of effective addiction treatment. The first one talks about a dignified environment, which we believe we have here. The next is integrating treatment that addiction and other mental health issues occur together, treatment of both occur together. Qualified and trained staff. Again, we have this group of highly qualified professionals that are full-time here that inform treatment plans and continuity of care. And I won't go through all of the other ones, but the bottom line is that defining quality of care means not detox only. If you are a heroin addict and all you get is detox, your relapse rate is 91%. So that hasn't changed from the days in 1964 when methadone maintenance hit the scene. Same percentage if you just get detox. So that is not enough. It needs to be patient-centric, which I've been talking about. It addresses the comorbidities and treats the comorbidities. It's a multidisciplinary and multimodality treatment model with many highly qualified, highly educated treatment professionals. We use only evidence-based treatment that is research supported, and we make sure that the patient is at the appropriate level of care using the ASAM placement criteria, and we have defined outcomes. So we'll talk more about that as I go on. Next slide, please. So creating a value-based model that works for substance use disorder. Next slide, please. And this is how to create that model that works. So you need to address the needs of the treatment center, of the payer, and of the patient. So all of these three need to be done in concert with one another. We need to recognize substance use disorder as a chronic disease, as I've been preaching over and over again, and treat it as such. It is not a moral failing. It is not a lack of willpower. And we utilize the ASAM placement criteria here at Caring. That's the gold standard, in my opinion, not just because I'm on the board of ASAM, but I believe firmly in it. We identify and treat co-occurring disorders right from the jump. So we have a treatment plan for just that, that is inculcated in the master treatment plan. Because if you do not treat the co-occurring disorders, it's likely the patient will go on to relapse. Even if they got adequate substance use disorder treatment, they have the ongoing mental health issues that will act as a barrier towards ongoing recovery. We need to identify and agree to key components of care, all evidence-based, and we need appropriate lengths of stay. So for some of our patients, like healthcare professionals, older adults, chronic pain patients, that stay is not 4 weeks, it's 6 weeks, because we know it takes a little longer for this subgroup of patients to actually reach recovery and maintain recovery in a journey of recovery. We focus on outcomes, which is so important to us, and we've been we've been measuring, I should say, outcomes for a long, long time. Outcomes now are being measured from the many value-based contracts that we have, not just with Independence Blue Cross, but many other providers as well. Focus on long-term disease management, continuing care planning, I said many times, so I won't repeat that. Next. So how do we define outcome measures? So what's verifiable? What can you influence? What can be measured with the tools available? So it's clear that I think we'd all agree that a simple phone call to someone and asking if they're sober is not adequate. We've had a program called My First Year that actually has the patient regularly talking to a counselor, not to replace aftercare therapy, but to be a resource for them going forward in recovery. So there's constant contact there. We also ask the patient to identify someone in their family, some loved one, or even their boss at times, so that we have another counselor actually asking similar questions and seeing what they think the patient is, how the patient is doing, I should say. And then, most importantly, we have a trust but verify way of looking at this. So we have random toxicology. So someone could say they're in recovery, but the toxicology may belie that and tell us that they're not in recovery. Next slide, please. So the Care and Independence Blue Cross model, which is what we're here to talk about and what Dr. Snyder and I presented at the RX Summit. Next slide. So this all began in 2017, and we agreed to a 3-year contract to see how it would go because we weren't sure. So it started out as a pilot program, and I can't say enough good things about the leadership at Independence Blue Cross. They were very engaged with us, and we hammered this out, and we found common ground and came up with a strategy moving forward. It allowed both Karen and Independence Blue Cross to assess, reassess, and value and find the value to each organization. Independence Blue Cross, the impact on its members, outcomes, costs, long-term member health was so important to them. And Independence Blue Cross is still evaluating additional data points, including what is the reduction in healthcare costs if someone maintains abstinence. The logical answer to that is they will spend less time in emergency departments, in urgent care settings, in doctor's offices, and so on and so forth. For Karen, it's all about cost, feasibility, and sustainability. So we were able to find common ground on all of that. It is a collaborative effort. It started as one and is even more so to this day. Engagement at all levels of both organizations occurred, and we did not compromise the level of care provided by Karen. So that same quality of care that we're known for is currently delivered to Independence Blue Cross patients. Next slide, please. So some of the components of the value-based model with Karen and Independence Blue Cross. So I'll define some terms. There's clinical control of the case that's retained by Karen. So Independence Blue Cross said, we're not the experts in substance use disorder treatment. You guys are. So we're going to let you do that. And then we're going to hold you accountable on the back end around outcomes. And we took a risk. So if someone relapses within 90 days, and goes to any level of care or even the same level of care, but to a different facility, that counts against us, right? So we were able to come up with that, shared risk that we thought was so important to the contract. Case rate reimbursement methodology, just like I talked to you about in physical medicine, there's a case rate that's given, say for a knee replacement or hip replacement, and it's all inclusive. And depending on your outcomes, that will determine your reimbursement. It must meet clinical need and defined by the ASAM placement criteria, which I've talked a lot about. There needs to be pre-authorization independent of Karen at admission to come into Karen. And due to the case rate, concurrent care is not necessary. And we begin continuing care planning at admission, as I spoke about earlier. Next slide, please. So some more components, we specified outcomes, the ability to step down to the next level. So we pride ourselves in a warm handoff to the next level and making sure that the patient gets to that next level and the linkage is very high to that next level. Because it's so important that once they complete our level of care, that they get to the next level of care and to the next provider. Otherwise, the ball will be dropped on the turf, and that is not acceptable. So readmission within 90 days to any network facility and any level of care will count against us, if you will. And that's where the risk comes in. If they come back here to Karen, there is no reimbursement whatsoever. No remuneration is given to us. It's on us. Next slide, please. So let's profile of Karen patients who are IBC members. They must meet ASAM criteria, placement criteria, which I talked about already. Karen does not determine level of care. A third party does that through ASAM placement criteria. We've had 1,551 patients since the relationship began. And the primary drugs of choice for Independence Blue Cross members was alcohol use disorder at 60% and all other substances at 40%. And there's a high level of comorbidities, whether they be physical comorbidities, because we treat a lot of patients who are cirrhotic, many of whom have a high MELD score, and then we have to put them on a transplant list. So there's a high level and very intricate amount of end organ damage that can come with alcohol use disorder and other substance use disorders. And then there's a high level of co-occurring mental health disorders and addiction interaction disorders. Next slide, please. So these are the results in 2019. And I'll tell you, we don't have 2018 here, but the results were very similar. They were 6.2% at 90 days in 2018. In 2019, the readmission, I should say, within 90 days was only 5.6%. You can see the other facilities that are not named, but are lettered, we outperformed each and every one of them. And the mean days to readmission were longer for our cohort than other cohorts in other facilities. Next slide, please. The 2020 results are still pending. So it's incomplete. It started in January and ended in May and was very disrupted by the pandemic. But you could see here our readmission rate, although higher than the ones I just quoted you, are still very low in comparison. And so as we get more information, as we're able to measure more and make sure that this is a 12-month look, we're hoping to see that number decrease as well. And the time to readmission is still best in class, as you can see on this chart. Next slide, please. So what readmission data is not, let's talk about that first. The only outcome measure we look at, but it is a verifiable data point. Independence Blue Cross continues to study other member data markers. Karen's internal quality measures also inform readmission rates, outcome measure initiatives. This is what the data is not. We have a My First Year Recovery program that I mentioned before, and that is not for our value-based contract members. What readmission is not, it's not data as an endpoint. We continue to discuss and research with Independence Blue Cross, and we'll provide more data. Continual quality improvement is the order of the day. We use internal and external data to improve our clinical care. And the answer for all, and it's also not the answer for all providers and families. It just works for us the way we've worked this out. Next slide, please. What readmission data is, it's focused on recovery. It's defined by not needing emergent, same, or next level of care, no matter where they go. It is improved quality of life that is measured, and it is engagement in the process and engagement in recovery. It's verifiable, It has a standard outcome measure for all treatment providers, a question, and all treatment providers question we would be able to answer. It is a starting point. I mentioned that we start treatment, we do not finish it. It's not episodic in that regard. We use the chronic disease model, which is a lifetime model of treatment. A strong argument, it is a strong argument that a 4-week length of stay improves outcomes. Again, some populations are longer, and at times it's also shorter depending on the patient. Next slide. And using the available data to improve care. So substance use disorder is a chronic brain disease, which I keep saying, and I'll just keep saying it. And long-term disease management plan begins at admission. Patients need to be able to move on to the next level of care. So we have to make sure that they are ready for that next level of care, and we have to find the appropriate next level of care. It may be a partial hospitalization next level of care, maybe an intensive outpatient next level of care, or a general outpatient next level of care. But we determine that over the course of treatment and begin the process at admission. So real-time readmission data allows us to know if our patients are prepared for the next level of care or to follow aftercare recommendations. We follow all of our patients, not just in my first year, so that we remove obstacles in getting to that next level of care, so our linkage is very high. We intervene and provide additional support and treatment so that the patient, if there are obstacles, we remove them to the next level of care. We evaluate what the breakdowns were and how we can improve on that. And we address systemic and programmatic and medical issues as well. Next slide, please. So what data from payers does for the treatment sector? Sorry, tongue twister there. It helps to establish outcome metrics. Okay, this is again borrowed from physical medicine, where outcomes will dictate standards of care. And that's what we're hoping for. It encourages the standardization of elements of treatment. It improves clinical competency and gives families information to make informed choices, because it's very important that that happens. Next slide, please. So lessons learned, back to you, Brad.
Great. Thank you, Dr. Garbely, for a very, very comprehensive dialogue about value-based models. So with the remaining time, I'm going to touch on a couple of high notes from the last couple of slides here, but we wanted to make sure we left some time for the questions that were curated. And we will be making this presentation available to all participants, as well as the ability to connect with any of us. So obviously a lot of information over the course of 50 slides in about 50 minutes. So we expect that there will be things that we can follow up on for you. So, understanding the basic takeaways as to what a value-based model is. And I think that top bullet point there really is the key one, that it is a partnership between payer and provider, where the payer is taking the risk of paying more for care justified by the provider taking risk, and both having a mutual investment in a better outcome for the patient. And when that dynamic works, it's best for the payer, it's best for the provider, and most importantly, it is best for the outcomes of the patient. Before starting down a road to do a value-based agreement, it's important to first and foremost understand your true cost of care. And so this requires a sophisticated financial analysis as to what are the direct costs and indirect costs of actually delivering care to your patients, understanding what needs to change, and understanding how to deliver, or what components of the care that you deliver really are the differentiators that produce the outcomes that you're looking to achieve. Going back to the bullet about partnership, it is sitting down and talking to your to the benefits provider that you're looking to work with, and having a transparent conversation regarding why you believe that this model could work for you. And as we move to the next slide, a very important part about this is to recognize that it needs to be something that is communicated clearly throughout the organization, and that there is mutual buy-in in the vision as to what this model looks like. I would say that the other part of it, if we're to move on to the next slide, is really having an open mind. That by piloting a program like this within your facility, you're going to find things that work and didn't work, and you're going to get feedback from the payer, and that's going to force organizations to evaluate their program and their model of care. So there has to be a willingness to take that feedback and implement that in a way that improves the care that's being delivered. Otherwise, it won't work. So if we're to shift to the Karen experience, that is really what we were able to do. I mean, we really wanted to respond to feedback we got in the beginning of our last strategic plan, which was that people who were able to access Karen were very pleased with the outcomes that they were getting, but people were frustrated that accessibility had become elusive to the vast majority of folks. And so in line with wanting to advance our mission of helping people in our communities, this was a way for us to continue to bring that quality of care that we had developed over 60 plus years, but do it in a way that allowed us to treat more people. And some of the great successes of that is that we've treated 500 and 600 more people in the past years each year than we were able to do before, while continuing to maintain consistency with these numbers that Dr. Garbely had talked about. So, the takeaway with this is that these models work for substance use disorder treatment. And when it works well, it's a triple win, where it is most importantly best for the patient. It's great for your organization, and it's a valuable relationship for the payer. And in the end, all of that stuff has a rising tide effect on our industry and the credibility of what we do. So I'm going to pause there. We have about 8 minutes left. So I know we have curated a list of questions in advance, and there may have been some that came through the chat as well. So I'm going to hand it to Julie, who is going to moderate this portion of the program. So thank you.
Thank you, Dr. Garbely and Brad. We will get to some of the questions. We had a lot come through. This one is for Dr. Garbely. Can treatment experiences that do not provide sufficient care contribute to a treatment-resistant developing in patients?
Yes, absolutely. Thank you for that question. Excellent question. It definitely, over time, can jade someone to the treatment industry and treatment in general. We just had a patient who had had multiple treatment experiences and was never able to access or maintain sobriety. I was involved in helping this particular patient come into Karen, and they could not have been more happy with their decision. And this particular patient made a point to thank me and said, I didn't believe you. I didn't think that you were better than the other places that I've been, but definitely the treatment that I've been provided is at a much higher level than anywhere I've ever been.
Great. I'm going to combine two questions that came in. How do you define evidence-based and research-supported therapies? Many providers operationalize these terms differently. And the second part would be, when referring to evidence-based practices, are you referring to manualized treatments or evidence-based therapeutic modalities, or both?
Is that for me as well, Julie?
Yes, please.
Okay. So it's about both. Okay. So it's beyond just clinical practices. It's utilizing the best in research and what is the evidence to support certain modalities that will achieve recovery and maintain recovery. Dr. Kelly, who I mentioned in my talk, has done research that shows that if you are abstinent for 1 year, it takes 1 year for recovery to be more likely than relapse. And in 5 years, you actually have the same risk of relapse as the general population has in manifesting the disease of addiction. So we have to look at evidence-based practices to get people to that point.
Great, thank you. Question for Brad. What is being done to reduce the risk of insurance fraud, including treatment centers not properly collecting copays and deductibles prior to benefit utilization?
Yeah, great question. And probably a topic that we've all heard about and had to talk about more than we would like to over the course of the past 10 years. The good news with that is that after a period of time where there really wasn't a lot of traction, the past 5 years, I would say we have seen good movement in many parts of the country in both enforcing existing laws, prohibiting offering inducements to patients to choose to come to certain providers, as well as prosecuting providers and other entities who are engaging in predatory behavior, capitalizing on people coming to their programs. The challenge has been that while some states like Florida, for example, where I had worked for the bulk of my career, which did a great job of finally cleaning up this segment of the industry, is that many of the programs have moved to other places. And so this is the laws can be developed at the federal level, but then, the onus is on the states to enforce them. And there's still a bit of a patchwork in how that is being done. But I think it's important, and from a definition standpoint, to really emphasize the fact that it is against the law to offer an inducement to somebody to go to a treatment center, and by waiving a deductible or a copay, that is exactly what is happening, and it is illegal. So continuing to pull that into the light of day, I believe, is a critical movement in our field, because going back to what Dr. Garbely discussed in one of his previous questions, is that one of the worst things that can happen when somebody is pulled into a negative treatment experience is that a population that is already 94% likely to not want to go to treatment is now going to have a tangible reason to justify why treatment doesn't work. So lots of variables reinforcing that challenging dynamic, and certainly malfeasance in the treatment sector is an exacerbator of that.
And we have time for one more question, and this is for Brad. Are there concerns that centers may try to control outcome measures by not accepting patients who are presenting as having a greater risk of relapsing?
Yeah, I mean, I think that, there's two parts to that. And I'd say that is, certainly a concern to be monitored, but it needs to also be recognized in the context of the partnership relationship between the payer and the provider, which is that we're sitting across the table and we decide upon a deal with an insurance company to treat their patients. If we are denying the vast majority of their patients, that's going to be a customer service issue for the insurer. They're not going to feel that the contract is providing value to them. So that's something that will get smoked out pretty quickly. On the flip side, we actually believe that there's benefit to this, because, to that same point of negative treatment experiences, probably the problem that we have now is providers putting the cart before the horse in taking anybody who has the ability to pay, either individually or through an insurance plan, and then trying to figure out whether or not they're the right program for that person. If a provider is held accountable to the outcomes and has to back that up with a guarantee of retreating that individual if they're not successful, it's forcing them to be much more thoughtful about ensuring that if they take a case, that they are the right program for that person, versus just somebody who is able to pay.
Great. Thank you again to Dr. Garbely and Brad for your informative presentation, and to all of our attendees for joining us today. As a reminder, this presentation is eligible for 1 continuing education credit. Watch your email for a link from cego.com to complete your evaluation. Karen has several more exciting webinars in the works. Please visit us at karen.org/webinars for more information and to register. Additionally, we are hosting a virtual open house for Karen's older adult program on May 20th. You'll have the opportunity to take a virtual tour, meet our staff, and ask questions about our services. Please visit our website or watch your email for more details. In the meantime, please reach out to your local regional resource director at any time for additional information, resources in your area, or questions regarding admission to any of Karen's programs. Thank you for joining us and have a great afternoon.
Thanks, everyone.
Thank you.